Good afternoon. I'd like to thank the organizers, the hosts, for the opportunity to speak to you about implementation and complex systems. What I'd like to do in this presentation is offer a set of ideas and suggestions or guidance from subfields of research that are not necessarily known to be integral to system science. I won't be talking about complex adaptive systems, systems theories, chaos theory, but instead a set of ideas and research approaches that I would argue have considerable relevance and value for studying implementation in complex systems, and can complement and in some cases actually substitute for some of the systems theories that again are more closely aligned with systems thinking. I'd like to begin with a slide that I know many of us have seen before, especially in the implementation research world, and point out that even though this is often used to point out that we often have the knowledge that we need, and the goal is to simply do, that in many cases when we're dealing with complex systems and implementation, we actually don't yet have all of the knowledge that we need. Or in some cases we have the knowledge, but we're not able to, or in many cases not willing to apply it and combine it and address the complexity of the challenge that lies before us. So I think the point here is that we do need to think about the additional knowledge that we need to achieve our implementation goals. We do need to think about the need to facilitate and stimulate and coordinate will, and of course the doing itself. So just as a refresher, in the ARC Learning Health Systems core competencies, the system science domain is stated as indicated on this slide. Let me highlight a few key phrases and ideas from this set of competencies. First of all, as I've indicated, there is an emphasis on systems theories, and that's not the focus of my talk. Although I do agree that those systems theories are very important, in that in the implementation research field, we would benefit from greater attention to understanding of and application of systems theories. But I like to highlight the phrases in red font. So our goal in taking a systems approach to implementation is to understand how different parts of the system, the delivery system, the consumers interact. I'll show in a subsequent slide the phrase, the sum is greater than the whole is greater than the sum of the parts. And I think that certainly is a key phrase and concept in the application of systems thinking. Systems thinking, again, is the focus of systems theories, but it can be understood to be broader. In the third bullet, rather, I'd like to emphasize the final word, interrelationships. And that we do need to understand those interrelationships and the interactions. And of course, this is all focused on the goal of understanding how to improve quality, equity, value, and other goals that we are pursuing in this field. So there are a number of definitions, of course, of systems, complex arrangements of individual elements, focus on interconnectedness, interactions, the feedback loops and emergent behavior that we see when we understand how these different elements interact. And again, the phrase that I quoted earlier, the whole is greater than the sum of its parts. The systems theories that I've alluded to are listed in the bottom half of the slide from an article listed at the very bottom. And these, again, are some of the highly specific specialized theories that we think of when we hear the term systems theories, systems dynamics. And these, again, are critically important, very relevant, but they're not the focus of my presentation today. What I'd like to do instead is offer a set of ideas and guidance from three closely related bodies of literature and thinking: embedded research, multi-level interventions, and complex health interventions, and argue that these will complement, and in some cases can actually substitute for, some of the more specialized systems theories. So let me begin with embedded research. And begin my definition and discussion of embedded research by highlighting the three different sources of knowledge and expertise that we know we need at the table when we conduct implementation research and other research within complicated delivery systems. We begin, of course, as researchers, thinking that perhaps we have the most important or the dominant knowledge. We could argue as to whether that's true or not, but I'll begin with that category. And of course, as researchers, we bring to the table knowledge of relevant theories and general principles from prior research. We bring the empirical evidence and insights that prior research has generated to help us understand implementation challenges and barriers and strategies. And of course, we bring an entire toolkit and set of research approaches and methods that allow us to systematically study implementation barriers and challenges and strategies and strategies for overcoming those barriers. But of course, our knowledge is only part of the puzzle. Without the knowledge of the service users, of course, we're limited in our ability to truly understand how systems operate and to truly understand their effects. And this is, of course, been a major focus of research in the last decade or 2 decades, beginning, I believe, with a lot of emphasis in the UK, perhaps Canada. The US, I think, was a little bit late to realize the importance of patient engagement and service users and public and patient and policy engagement. But we know that service users bring to the table deep insights into their own needs. Their own values and preferences. And of course, insights into the likely acceptability, the feasibility and value, and even the effectiveness of the different innovations and interventions that we, ideally in collaboration with service users, patients, clients, consumers, would develop. So that's category 2 or stakeholder group 2 that needs to be at the table with us as researchers and scientists. And finally, service providers, the health professionals, clinicians, administrators, and this includes policy leaders as well, not just those who are in the front line who are leading delivery systems. Of course, they bring to the table their professional knowledge and skills, insights into their own attitudes and beliefs, the professional norms that often guide their behavior as much or more than their knowledge, their own values and preferences, which are critically important. And again, a distinctive perspective on the likely acceptability, feasibility, value, and effectiveness of interventions. So the key point here is that our efforts to implement, to understand complex systems, to understand how to improve those systems, require not just the knowledge and skills and engagement of scientists, but instead these 3 groups. And I think this illustrates a general point in a challenge that we have in the implementation science field and other fields that study systems and service delivery. And that is the dominance in the fact that we are often misled or incompletely led by the dominance of basic research approaches and clinical research. So if we're conducting basic research, we as researchers are probably the only group that needs to be at the table to be involved in that research. Again, Pecori and others who have emphasized patient engagement are acting on the realization that to study the effectiveness and outcomes of clinical interventions, the researchers don't have all of the requisite knowledge, that we need the recipients, the targets, the beneficiaries of those clinical interventions to help us understand their effects. And even before that, to help us understand what the key questions are, how to approach those questions, how to design and conduct the studies. So for clinical studies, patient engagement and the engagement of consumers is critically important. When we study healthcare delivery and other social service delivery, it's the service providers who are oftentimes missing but critically important. So again, if we are inappropriately dominated or influenced by approaches from basic science and clinical research, as I've said is too often the case in implementation, then we neglect to recognize the importance of full active clinician and health professional and service provider engagement. And that leads to the concept of embedded research. So the definition of learning health systems and literature on learning health systems emphasizes perhaps indirectly the importance of embeddedness. The phrase that and the idea that learning health systems involve using data that were developed by and for delivery to study and improve delivery clearly implies the need for improved involvement and engagement of those who are involved in that delivery activity. We can't, as outside researchers, come into a healthcare system and observe and study and collect data and achieve the goal of a learning health system. It has to be a full collaboration between those who are delivering care and those who study and support care. So the concept of embedded research in some ways represents a midpoint in a continuum between pure quality improvement and practice work at one end, where the goal is to study and improve a system with the goal of immediate benefits and improvements. The other end of the continuum being pure scientific research, where the goal is to develop scientific, often generalizable knowledge, and to publish and share that knowledge without necessarily any interest or focus on improving care in the near term or in the sites or the subjects that are being studied. Embedded research attempts to do both simultaneously. We would like to emulate our quality improvement colleagues and achieve near-term improvements as a direct result and outcome of our work. But we'd also like to emulate our scientific colleagues in producing useful scientific generalizable knowledge. This, of course, implies, or in fact requires, full partnership and collaboration between service users and service providers and researchers. It's not the occasional focus group or the periodic advisory board where the frontline clinicians and health system leaders review our progress as a research team and offer guidance. They need to be active members of the research team involved at every step of the way. And embedded research, of course, is related to and might even be viewed as encompassing other concepts and sets of ideas and approaches: public and patient engagement, engaged scholarship, which began in education but captures the same ideas, partnership research, community-based participatory research, and other forms of participatory action research. So all of these are related and integral to the concept of embedded research. So again, the key point that I'm making here is that embedded research is one of the necessary but not sufficient approaches to studying complex systems and studying and improving implementation in complex systems. So let me move to the next set of ideas and research approaches, and that is a research on multi-level interventions. Again, a diagram and a set of ideas that I know are familiar to all of us in the health and social service research fields. But the point is that many of the outcomes that we are interested in understanding and improving are influenced not by factors at one level or two, but by multiple levels. In the socio-ecological model captures this quite nicely and points out that the kinds of outcomes that we are interested in as implementation researchers tend to have influences that occur at the point of care. Those are patient influences as well as individual health professionals. There are team and microsystem factors moving up a level to the organization and then the system, a set of additional factors that influence those ultimate patient and consumer outcomes or client outcomes. And then looking outside the organization to professional norms, to consumer and businesses and others in the local region. And then moving up a level to national and even international regulations. And the contrast here, of course, is to what we often view as 1950s medicine, where we had an individual physician working from his or her, and in the case of the 1950s, of course, primarily his own knowledge and training and views, combined with what was too often a somewhat passive patient. And that was the extent of the influence. Insurance companies would reimburse, hospitals would allow physicians to admit and practice in a way that they deemed relevant, and there were relatively few outside influences or relatively modest strength of influence from these other factors. But again, we're no longer in the 1950s, and things are much more complicated for us, and we do need to fully embrace the socioecological model in understanding how to study, understand, and ultimately improve client outcomes. So why do we need multi-level interventions? I think it's obvious from the previous slide and my comments, but this is a list of some of the key issues for which multi-level interventions are critically important. And the version of the onion on the left is slightly different from the previous version, but again, captures this idea of nested levels of influence. So for implementation, and as we look back on the history of implementation research over the past 10, 20, 30 years, I often characterize our implementation efforts, especially as researchers, as too little, too late. We will often identify 1, 2, or perhaps even 3 key barriers to implementation. We will deploy implementation strategies or combinations of strategies that address 2 or 3 of those barriers. And oftentimes we are doing so in multi-million-dollar, multi-year studies that involve a considerable amount of effort and cost. There is often some impact, but again, too little, too late. And back in the 1970s, the dominant finding, I would argue, from many of the studies of what at the time we called changing physician behavior, presented the finding that we did manage to improve intervention physicians' attitudes or knowledge or skill, but their clinical practices didn't change, again, because we were addressing only 1 or 2 barriers at 1 or 2 levels, but leaving many others unchanged. The image that I often have in mind when I think about this and the issue of multiple barriers and the need for multiple strategies is to view efforts to change professional practices as akin to pushing a large boulder up a hill. And not only is it very heavy and difficult to push, but in fact, that boulder is often attached by a number of ropes and chains and bars that are holding it in place. If we deploy a 2 or 3 component intervention that manages to loosen or eliminate 2 or 3 of those ropes and chains, but others remain, that boulder ain't moving, as they say. So again, we need to think about the need for multifaceted, multi-component, multi-level interventions in order to achieve change in practice. I'll often give a talk that walks through this set of 9 necessary but not sufficient conditions, highlighting the fact that for professional practice change in social service delivery, in healthcare delivery, we often need to see conducive conditions across this entire list. We, of course, need to have valid, legitimate evidence that's accepted by clinicians and other health professionals and social service professionals. They need to have the knowledge and the skill. Professional norms are important. Oftentimes we lack definitive evidence or knowledge and instead rely on professional norms. And one of the hallmarks of the professions is the fact that professionals are guided not by organizational rules and regulations, but instead often by their own knowledge and learning and by professional norms that arise and are maintained in the community. That health care professionals look to their outside peers as much or more than inside organizational rules. So that one condition is critically important. Back in the 70s and 80s, we would often talk about report cards and external reporting and the idea that if we can only produce public reporting of quality gaps and performance, we could incentivize clinicians and systems to improve. Again, that condition, that conducive condition is necessary often, but not sufficient. Regulatory and fiscal factors, of course, are important. Consumer acceptance as well. We can provide physicians with report cards showing their performance and highlighting quality gaps, and we can provide them with CME and incentives. But if patients or clients are resistant to the evidence-based practices we are trying to facilitate, the healthcare professionals may be limited in their ability to achieve meaningful practice change. The concept that the squeaky wheel gets the grease, I think, is important when we think about evidence of quality gaps. Oftentimes, if we will deploy a new educational strategy or computerized reminder to health professionals, in their mind, they're thinking, yes, I'm aware of that evidence, I'm aware of that guideline, I know what to do. We need to actually provide them with evidence showing that their practices do not conform to a sufficient degree to the evidence-based practice or the guideline in order to ensure that they are motivated to change. But we not only need to provide evidence of quality gaps, but we need to understand the root causes of those quality gaps. An educational intervention might be effective in a situation where the quality gap is due to lack of knowledge, but it's not going to be effective when the healthcare professionals know what to do, and there are other logistical or economic constraints or patient resistance. So understanding the root cause of the quality gaps is, again, necessary but not sufficient for improvement. And finally, effective and feasible logistical arrangements, the idea that knowing what to do, having the appropriate incentives, and all of the other conditions that may be conducive to practice change, we still may not see movement in that boulder if the clinicians lack the time or the space or the equipment or the staffing needed to adhere to the evidence-based guideline. So again, this relates to the concept of systems in that there are multiple moving parts. Multi-level interventions are needed where we identify the root causes of implementation gaps and barriers at all levels, and we deploy a package of implementation activities that are specifically targeted to the gaps and the barriers at every level, and do so in a way that is coordinated. So I think this slide summarizes basically what I've just said, that we need to ensure that our implementation strategies address all of these needs. And I should say that the previous list of conditions, necessary but not sufficient conditions, is not necessarily a checklist for the intervention components or activities that we need, the implementation components. Instead, it's a checklist to assess current conditions. And if current conditions on one or more of those items are already conducive and supportive, we don't need to deploy new implementation strategies. It's a form of, a checklist for a needs assessment to identify the problematic conditions and to, again, design and deploy the intervention activities, the implementation activities to address those conditions that are not yet conducive. So just a couple more comments about multi-level interventions before I move to the third and final set of ideas. And that is that interest in multi-level interventions and MLI research has increased significantly over the last 10 years or so. NCI, in many ways, within the NIH, has been at the forefront of this effort. It hosted a large conference in March 2011 to talk about multi-level interventions across different phases of cancer care, the cancer care continuum. The results of that conference are written up in a still widely used and quite valuable and timely monograph, of the special issue of the Journal of the National Cancer Institute that I would encourage you all to take a look at. I spent a year on an IPA at NCI a couple of years ago, working with Erica Breslau and others to design a multi-level interventions training institute, similar to TIDERC and some of the other training institutes that NCI has hosted in implementation research, but in this case with a focus on multi-level interventions. We delivered that program through virtual distance means last year, and we're now about 1/3 of the way through the 2021 version. So that's, again, another example of increased interest and attention to multi-level interventions. I should say we trained 50 trainees last year and another 50 this year, and there has been considerable interest. The NHLBI recognizes and has also invested effort in understanding and stimulating interest in multi-level interventions through the workshop and other efforts. And then at the bottom of this slide is just a short list, a subset of the many funding announcements that in many cases explicitly mention multi-level interventions in the titles. In many other cases, they mention multi-level interventions as an area of interest within the body of the funding announcement. But again, this is a subset, a small list of some of the funding announcements and examples of interest in multi-level interventions. So let me move to my final set of ideas and approaches that I would assert are directly relevant to and valuable for understanding complex systems and implementation in complex systems in a way that complements and can often substitute for the use of the more specialized systems theories. And that is an emerging and rapidly growing set of ideas and activity focused on understanding and studying and guiding the design and use of complex health interventions. So let me begin by stepping back and talking a little bit about what we as researchers in implementation and other fields of health-related research are trying to accomplish or trying to contribute. And oftentimes our research is meant to answer policy leaders and practice leaders' questions. Oftentimes they're interested in understanding whether an innovative treatment or approach works or if it's effective. In the case of drugs, the FDA would like to know whether a new experimental drug should be approved. Insurance companies would like to know if it should be funded and promoted. Regulators often would like to know if it should be mandated, or health system leaders would like to know if a new healthcare delivery model should be rolled out system-wide. P&T committees, of course, would like to know if new drugs should be included in the formulary. And even when we think about individual clinicians and healthcare professionals, oftentimes they too have in their mind the simple question, is this effective? They'd like to know if they should use the intervention. So as researchers, in trying to answer the effectiveness question, we will often conduct a standard RCT, and we ask our data whether outcomes differ for the intervention group versus those in the usual care group, or in the case of comparative effectiveness research, are outcomes better for intervention A versus B. We often have the sample size and the ability and the need, of course, to understand subgroup differences and contextual influences to understand whether there are certain features of the intervention targets or subjects, as well as the settings that influence outcomes. And again, an RCT is typically the go-to gold standard method, but the focus of this kind of research is on impact and outcomes. Do outcomes differ? In many cases, for drugs and for a few complex health interventions, it is useful to ask and possible to answer the question, does it work or is it effective? We can usually, or often, or sometimes in the case of complex interventions, actually produce a definitive answer. Yes, outcomes did differ. Yes, the intervention does seem to be effective over relatively broad types of settings and types of subjects. But by and large, when we're dealing with complex health interventions, various health promotion programs, various rehabilitation interventions, various healthcare delivery interventions, and of course, implementation strategies, if you ask the question, is this intervention effective? The answer is sometimes, or it depends. We don't see robust patterns of effectiveness where we can definitively include that a certain intervention is effective. The answer varies. Just a side note, and that is what represent, at this point, the most formal, widely accepted definitions of complex health interventions, and that is interventions that have multiple components that typically interact. Those multiple components, of course, target multiple entities, typically at multiple levels, but not always. We can have single-level complex interventions. These interventions are almost always highly adaptable. And because of the multiple components and the multiple levels and targets, the intervention effects typically occur through multiple pathways that are highly mediated and moderated and not very simple. So when we study complex health interventions, and I make the statement that they are generally speaking not robustly effective, but instead the answer to the effectiveness question is it depends or sometimes. Let me illustrate what I mean by that in terms of some empirical data. So this is a pattern of results from a hypothetical implementation study that I don't know has ever been seen in publication, where our blue intervention group shows very significant improvement in adherence, for example, to an evidence-based clinical practice guideline, whereas the yellow or light green control group shows no change in adherence on average. And these are either on the y-axis number of physicians or health professionals or the number of sites. But this is the sort of result that any of us would obviously be thrilled to see in an implementation study where our innovative implementation strategy produced highly significant improvements in adherence and outcomes. But again, we don't often see those results. This is much more typical in terms of the findings from implementation studies and other studies of complex health interventions. We see relatively weak effects. The dark green is overlap. Those are places where both the intervention and control sites showed changes in adherence. And if you were to try to plot the average effect for the intervention versus control, you might see a very small difference. But generally speaking, the variance is so high that it doesn't make sense, and it's not possible to say that this intervention is effective. If you are an intervention site in the blue or green, you're almost as likely to see an improvement in adherence as you are actual decreases in adherence, and similarly for the usual care or control sites. So the question here is not whether there is a difference between intervention and control, but instead what factors explain sites that end up on the right-hand side of these distributions versus the left-hand side. We need to focus on the heterogeneity, not on average effect sizes. So why do we see these very weak effects and very high variance and very high heterogeneity when we study complex health interventions? First of all, we see considerable heterogeneity, variability, or adaptability in the targets. When we study drugs, we might argue that patients and their physiology tend to be somewhat more similar than when we study communities or organizations. Now, again, we could argue that point. There are, of course, genetic differences and many other differences in patients. But generally speaking, I would assert that complex health interventions that target behavior and organizations, communities, see much greater heterogeneity and much greater change over time in those settings. The underlying pathologies, root causes tend to be more heterogeneous as well. If we see low rates of adherence to a certain guideline, in some sites it may be due to physician resistance or health professional resistance or lack of knowledge or lack of conducive logistical arrangements and support. In other cases, all of those factors may be present in those conditions, but it's the patients that are resistant. One of the examples that we see in some of our research at Kaiser is our efforts to improve HPV vaccination rates. And we see highly variable vaccination rates across our region. In some sites, in some parts of the Kaiser Southern California region, the root causes of low vaccination rates are patient resistance. Physicians, health systems, nurses are doing everything they can to try to encourage the kids to be vaccinated, but the parents are resistant. In other parts of the region, parents are highly adherent or highly open to and accepting of physician recommendations. But it's the physicians or the health system that are not doing everything they can to encourage high vaccination rates. So again, heterogeneity in the underlying root causes and barriers will result in heterogeneity in outcomes and effectiveness. And then one of the key issues that I'll spend some time talking about in the next several minutes is the fact that the programs themselves tend to be highly heterogeneous. If we are studying a drug, that drug comes in the same chemical formulation from every factory over time. If we're studying a health promotion program or a multi-component rehab program or an implementation strategy, irrespective of our efforts to try to achieve fidelity, we know that that program will differ. The components will differ, the staff that are delivering the intervention will differ, not only across sites, but across time as well. The organizational learning curve phenomenon tells us that programs will change and adapt over time. So again, these are factors that contribute to heterogeneity and weak effects. This is a diagram that illustrates a typical causal model for an implementation study that's focusing on guideline adherence. We know that guideline adherence in clinician behavior is influenced by their attitudes and norms, by their knowledge and skill, by their motivation and activation. And each of those precursors or influences on the behaviors of interest are themselves subject to different influences. There are external factors. I mentioned earlier professional norms that influence attitudes. We also can deploy internal opinion leaders to modify those attitudes. We can use education and training, of course, to try to improve knowledge and skill. Motivation and activation can often be influenced by leadership activities, but they're also influenced by financial incentives. But those financial incentives don't have homogeneous, stable effects. The financial incentive or the effect of a $20,000 bonus for a new family physician fresh out of training with a $150,000 a year income, the effect of that incentive on his or her efforts to improve guideline adherence, of course, is likely to be much greater than the effect of that $20,000 bonus on a surgeon whose income is in the $500,000 and up range, and who is older and more established, and unfortunately doesn't pay much attention to patient satisfaction scores and other sorts of factors that lead to bonuses. So again, we have complicated causal chains and causal effects with different mediation and moderation, different external contextual influences. And this is the sort of scenario that we often are trying to study and change as implementation researchers. So what do we do with this? We know that complex health interventions can be modified and tailored. We know, again, that they will be, irrespective of our efforts to achieve fidelity, but more importantly, they should be tailored. They should be adapted and tailored to local circumstances. Oftentimes I'll use the phrase adaptation happens. And to me, that means that we should not be ignoring adaptation or trying to suppress it and trying to achieve high rates of fidelity to a manualized intervention, but instead we should be embracing adaptation and tailoring. We should be studying it, and ultimately we should be guiding adaptation and tailoring. The complex causal links and pathways that I'd illustrated in an earlier slide, to me, are akin to the game of mousetrap, which many of you who are in my generation may remember playing. And it's basically a set of causal links in a long causal chain where we drop the marble at the beginning and we watch it, the mechanism play out, and hope at the end that the trap falls on the mouse. If we were to conduct a typical clinical trial and focus only on dropping the ball in the beginning, and then focusing only on running to the end and looking at the trap, and half the time the trap falls and half the time doesn't, we don't have much to go on by way of trying to improve effectiveness. We need to study the causal pathways and the mechanisms of effect. We need to recognize the heterogeneity and the adaptability. This has a number of important implications for us as researchers, one of which is that the concept of a manualized intervention, which lays out the steps of the intervention in fine detail, does not allow for adaptation and tailoring, and often can be counterproductive. The concept of core components, as it's often understood, which is again a set of very specific activities, again can be counterproductive. And the alternative that's offered by the complex health interventions literature is the concepts of core functions and forms. And these were initially introduced by Penelope Hahn a number of years ago, and have not really had much influence in the study of complex health interventions and implementation until relatively recently. And there is now a very rapidly growing body of literature and interest and focus on trying to identify core functions and forms rather than thinking about core components. And I'll illustrate these in the next slide, but the basic definition is the core function of an implementation or intervention activity is its purpose or its intended effects, rather than the activity itself. The activity or the format or the way that that core function is operationalized, or the actual component, is labeled as the form. So when we think about physical activity as a core function, we can operationalize physical activity through walking or running or swimming. We can operationalize the core function of patient education through printed materials or videos or nurse education. So the idea of a manualized intervention that specifies 20 minutes of walking or that specifies use of physician education, again, can be counterproductive. We know that some patients are more open to physician education than nurse education or peer education, whereas others, in the HPV vaccination example is a nice example here, physician education in attempts to influence patient behavior often can be counterproductive and can reinforce an a priori belief on the part of patients that physicians are agents of drug companies trying to sell damaging vaccines. For that subset of patients, peer education is likely to be more effective. So again, our intervention should not specify a form or an activity, but should specify the underlying goal or purpose with a menu of forms, where we would select from that menu on the basis of the forms that are most likely to be suitable for our specific target intervention. So, briefly, some of the key intervention implications, rather, form versus function. I think I've covered each of these. We know that manualized interventions can often be counterproductive. We should not be focusing on core components or activities or forms, but instead thinking about core functions. Our measurement of fidelity should not measure fidelity to the manual or to form, but instead fidelity to the core function. And again, estimating main effects is often counterproductive or of limited value because the main effects or the average effects are close to zero. We need to understand how these interventions achieve their effects rather than whether they're effective or not. This is a short list of some of the key research approaches that are useful for and used in studying complex health interventions to complement RCTs. And this is another way of summarizing our role as researchers when we study complex interventions. We are not trying to support dichotomous yes-no decisions. It's not useful for us to pursue an answer to the question, is it effective or does it work, or which is more effective? Again, the answer is always, it depends or sometimes. Instead, we need to understand how it works, why, when, and for whom, some of the key questions in realistic evaluation. But perhaps most importantly, how can we enhance its effectiveness? We don't have the option of enhancing the effectiveness of a drug by modifying its chemical formulation. We do have the option and the ability to enhance the effectiveness of complex health interventions by modifying their chemical formulation, in a sense. And we should be focusing not on the impact and measuring impact, but instead more of a focus on understanding and measuring process. So again, rather than how do I choose an appropriate program because it's effective or not, we need to pursue these kinds of questions. How do I deploy the program? How do I tailor it? And how do I modify and manage the setting? Again, we have limited ability to modify patient characteristics. We can't modify their genetic profile. We can, of course, encourage healthy eating and physical activity, but we can do much more to modify organizations and modify patient attitudes and behavior and knowledge as a way of enhancing and improving outcomes. So the way that we study and use complex health interventions is summarized by this slide. And again, a repeat of the key point, which is not to produce evidence of effectiveness, but instead evidence and insights into mechanisms of effect and how to modify and tailor complex health interventions. So again, I'd like to thank the host. I look forward to a discussion, questions and answers, and more discussion into how these kinds of bodies of ideas and research approaches can complement, or in some cases substitute for, systems theories as we try to understand and influence implementation in complex systems. Thank you.